Okay, so just as people are joining, I'm just gonna let people know what's on the schedule for the next few weeks. Today we have the diabetes team here today at the beginning to give us a presentation. And depending on how long that takes, we do have a case that we can tuck into the middle. And then Sheila has a bunch of clinic updates for Bartlett that are gonna happen in the latter half of the hour. So we'll sort of see how things go in terms of the timing. Then next week, please send me any kidney cases or questions. Actually, someone emailed me just a few questions that they wanted for Dr. Fine next week, not necessarily a specific patient. And that's another great way for us to squeeze all we can out of having a renal expert with us. And then the following week, we're back into our annual clinical care of the patient with HIV, where we have an update in diabetes management from Dr. Todd Brown, and then a talk on the antiretroviral pipeline from Ian Cook, one of our amazing pharmacists. And then on the 25th of February, we're going to have an EPIC sprint update. So I think a lot of people have heard about that before from Joyce, and their team will be here to answer questions about the sprint and also to tell us a little bit about what's going to happen in general. And then Yuka is going to give a talk about the state of the clinic, which will, I think, be very akin to a State of the Union address. So I will stop sharing, and then if the diabetes team, if you guys have, oh great, you do have slides. And so maybe you want to introduce yourselves and what you're going to present today to those of you and again, the audience here, providers in the Bartlett Clinic, but also from our county HIV programs and several other locations. So thanks so much for joining.
Thanks for having us today. So I'm Nisa Maruthur. I know many of you. I'm a general internist here at Hopkins. I practice at Green Spring Station, but I also am the co-medical director focusing on diabetes prevention and community-based programs for the newly named JHM Diabetes Prevention and Education Program. Ness, do you want to introduce yourself?
Yeah, sure. Hi, everybody. I'm Ness Mathioudakis. I'm a faculty member in endocrinology. My clinical focus is diabetes, and I'm the co-medical director of this partnership focusing on the diabetes self-management training part, as well as sort of anything that relates to clinical services in this exciting partnership. So thrilled to be here. Thanks for having us.
We'll start out with a few objectives. I did co-invent an online DVP that it doesn't make any money, and it's not going to be discussed during this presentation, but wanted you to know that. Today we were really going to focus on the two evidence-based programs that the DPEP is focused on, the diabetes prevention program and diabetes self-management training. I'll start off with the DPP. Hopefully by the end of our talk, you'll be able to recognize which patients should be considered for referral to these programs and then how you do it. So hopefully it should be pretty practical for you. Wanted to give you a little context because I know this group is a lot of you are involved in research and in our clinical operations for the school. The DPEP is funded by, we have an HSCRC grant that goes over it's a 5-year grant. We're in the second of 5 years. A huge initiative, $43 million to increase participation in 2 programs. The diabetes prevention program and diabetes self-management training. It's across the health system, but we have a particular focus on the JHH and Bayview zip codes, especially for the DPP. And so, one of the goals of this program is to make sure that we're able to continue offering these programs after the grant is over, which is why I was telling you about it in the first place. So we have a lot of resources now, but we need referrals and need to really build up the case that we have a need for this in our population over time. I'm just going to launch right into the diabetes prevention aspect of it, which really focuses on the population with prediabetes. The CDC just released the most recent diabetes statistics report this week or last week, and the prevalence of prediabetes is now 38%. In the US among adults, it's 96 million adults. Most people, 80% of people who meet criteria for prediabetes are not aware that they have it. And there are lots of reasons for that. And then only 4% of people with prediabetes have been referred to a DPP, which is the standard of care. And I'm going to talk about that program today. I have the diagnostic criteria here for prediabetes, and I will just leave those there. I won't go over them in detail. The other thing I wanted to mention is that a lot of people don't realize that even before, diabetes, the diagnosis is on a spectrum. I mean, the diabetes is on a spectrum in terms of more hyperglycemia is worse. And when you're in the hyperglycemia range of prediabetes, there's still an association with premature mortality, cardiovascular disease, neuropathy, chronic kidney disease. So it's an important condition even before you have diabetes, and it's very common. The program I'm going to talk about today is the Diabetes Prevention Program, and it's really informed by several trials across the globe that looked at lifestyle interventions for preventing diabetes among high-risk people. They all had kind of 3 to 5 years of follow-up, enrolled people at high risk of developing diabetes over time. You can see the diabetes incidence in the control groups here. And over to the right, I'm showing you the relative risk reductions, the absolute risk reductions, and numbers needed to treat for doing an intervention like the one I'm going to describe today, the DPP, compared to what's standard, which is oftentimes our advice. And you can see here the numbers needed to treat were very low. The absolute risk reductions, of course, then were very substantial. And that's really the main source of the evidence is these efficacy trials. The standard of care, and I'm not going to get into some of the evidence that came up to the standard of care, but the standard of care today is really for us to screen people who we've already identified with prediabetes annually. And there is now a BPA that shows up to remind you to screen folks. And then the interventions that we really should be doing would be referral to a structured lifestyle change program like the DPP. Where the goal is to lose weight, because that's the strongest risk factor for type 2 diabetes for people who are at risk, and then also to achieve 2.5 hours or more of moderate intensity physical activity each week. Metformin is also an option. It's not something that I'm talking about today, but these are the ways that we can prevent diabetes in our high-risk populations. I'll spend the rest of the time talking about the program we have here at Hopkins and how you can refer. So the first thing I wanted to point out is we have a pretty big team that's here to support the patients that you refer. I'm one of the main medical directors, but we have a team of coaches, administrative folks, community health workers, and data folks who are supporting us providing an evidence-based program. We've been providing the DPP at Johns Hopkins, really with a focus on the Johns Hopkins Hospital community since 2016. We've had over 200 people join now. Several of them are still active. So I have 178 who've kind of had the potential to complete. We keep about 70% of people who join the 12-month program in the program for the whole 12 months. And attendance across our 33 sessions is 91%, and we achieve an average weight loss of 5.4%, which is clinically significant and should be sufficient to lower the risk of diabetes. Historically, we provided the program in community-based sites. We continue to do that, but it's all virtual through Zoom right now. But we do, we think one of the main strengths of our program is that we do offer it in conjunction with community partners and not just kind of solo as a solely clinical service. Here's who's eligible. So a lot of your patients are eligible. People who meet criteria for by labs for prediabetes. If you have a history of gestational diabetes and you have an elevated BMI, you're still eligible for the program. And the referral actually reminds you of these things, so you don't have to remember necessarily. I do want to note this is not for patients with diabetes, and that people who have diabetes should be referred to the program that Ness will be talking about, Dsmt. So we have your all of your hopefully diabetes related and needs covered here. So how do you refer? You just type in DPP into the orders box in Epic. You can type in diabetes prevention, and there are other synonyms programmed in there. And basically, you get this here. If your patient has data on BMI and A1C, for example, all of that will pre-populate, all the buttons will be depressed, and you can just hit accept. If not, like say they didn't have a recent weight, which would be unusual in a clinic visit, but we're obviously having that with telemedicine. You may have to enter some of the data on BMI and their lab values, but this is pre-populated for most people. Hit submit, and we, on our team that I showed you, will call the patient within 2 to 3 business days. We'll talk to them about the program, tell them more about it. This is about a 20-minute call where we'll go over making sure that they're ready to join. So you don't have to have, you shouldn't feel that there's a lot of pressure for you to provide a lot of information to the patient. We'll do that. And then we'll schedule them for the next group. It's a group-based intervention. So we do, the usual wait's probably down to 2 to 4 weeks, depending on where we are in starting cohorts. And then we will give you an update at the time of enrollment and also at 6 and 12 months. So we do try to stay in touch with you and let you know if we can't get in touch with folks. This is an overview. So this is one of our sessions that was conducted at Zion Baptist Church. Now we're through Zoom, but basically when a participant shows up, and now it's virtual, they'll have a check-in with their coach or our CHW and give us their weight, their physical activity minutes. We do a lot of self-monitoring in the program. And then there'll be a group check-in where they start talking about how they did over the last week or two, trying to consolidate some of the information that was covered during the last session. New content is covered, and then there's a SMART goal time where people can kind of take what they learned that day and figure out how they're going to apply that for the next 1 to 2 weeks. So it's a behavioral intervention. I won't go over the details, but not shockingly, we focus on healthy nutrition, physical activity, stress, coping, emotional eating, and really the goals of the program are to lose 5 to 7% of your baseline weight, which is what's been shown to reduce the risk of diabetes, and then achieve, like I said, 2.5 hours per week of moderate intensity physical activity, which is typically walking. And a lot of our people start with 0, so this is something we work with them on. I have my contact info here. A lot of you know me. Please email me. We'd love to know if there are things that are not working or things you'd like to see, pretty much any part of the process, because we see you guys as really important partners in helping us make sure that we can offer this program for our patients. I will answer questions in the chat and then pass it on to Ness. Thank you so much.
All right, so we're going to shift gears now and talk about diabetes self-management training, or DSMT. So this is a program that is accredited by the American Diabetes Association, and Hopkins Medicine has had a DSMT program in place for decades, but it really was not sufficient to meet the needs of our patient population. We had one certified diabetes educator who was really delivering what is intended to be DSMT, and I'll share with you some exciting, our expanded program and increased capacity here. So next slide. All right, so just a quick slide about the state of diabetes care. So we know that 90 to 95% of people who have diabetes have type 2 diabetes, that medical costs are more than double for people with diabetes. And there's been some recent data published out of the Welch Center at Hopkins showing that despite new agents, GLP-1s and SGLT2s, we're really not seeing significant improvements in terms of attainment of therapeutic targets over time. And there are significant racial disparities with respect to prevalence of diabetes and diabetes complications, ED visits, admissions in Maryland, particularly within Baltimore City. And this was the whole reason why the state put out the RFP for this grant. So next slide. Okay, so what is DSMT? DSMT is actually standard of care for all patients with diabetes. This is an ADA recommendation. You'll see it in every annual update. It is recommended that any patient at the time of diagnosis, Anissa, if you don't mind just clicking through the next few, be referred for comprehensive self-management education and support, or annually, or when they're not meeting their treatment targets, or whenever a complicating factor develops, like a diabetes complication, foot ulcer, kidney issue, vision problem, or during a transition in care. So like new to the area, new primary care physician, new insurance, when things can kind of fall off in terms of medications and adherence. Next slide. Why is DSMT standard of care? Well, it is because there's a very strong evidence base from, I think, upwards of 20 trials showing that DSMT is effective. It lowers A1C, it improves cardiovascular measures like blood pressure and lipids. It's been shown to improve medication adherence and diabetes-related complications. And interestingly, there have been several studies showing an association with reduced all-cause mortality. It increases healthier lifestyle behaviors, confidence and self-efficacy of our patients, and importantly, decreased healthcare costs and potentially avoidable utilization, admissions, and ED visits. And so one of the important elements of this partnership is that we need to create a sustainable program, and to demonstrate that this is worth funding long-term, we need to show that the program has a return on investment, and we anticipate that as more patients come through the programs, that will make an impact in terms of glycemic control, but also reduced PAU. So despite that really strong evidence-based, unfortunately, studies have shown that only 5% of eligible patients with diabetes have ever received DSMT, and we hope that this program will make a big change here in getting our patients into the service. Next slide. So what I'd like to talk about in the next few slides is just introduce you to our DSMT team. We'll go through what DSMT really is, because I think there are a lot of misconceptions or confusion on the part of providers and patients about what this is. And then importantly, how to refer to the program. Next slide. All right, so this is our team. As I mentioned before, we had one diabetes educator, and I'm thrilled to share that we now have a group of 8 talented certified diabetes care and education specialists who are positioned throughout the Maryland area in Johns Hopkins Medicine at several JHCP sites, 3 of our hospitals, and School of Medicine practices. In addition, I'm the medical lead of the program. We have some administrative support, and Jean Arnold, who has been our sole diabetes educator, has taken the lead in managing this group of educators, as well as Caitlin Nass, our nurse practitioner, is the director of our intervention. So we've got capacity. So who is eligible? Next slide. So this is pretty simple. Anybody with diabetes of any type is eligible for DSMT, type 1, type 2, post-pancreatectomy, gestational. You don't have to think too hard about this. Adults with diabetes should receive this service. Next slide. All right, so a little bit about the program. So again, anybody with diabetes is eligible, and the intervention is delivered by a certified diabetes care and education specialist, formerly referred to as certified diabetes educators. These are individuals who may have other clinical credentials, nurses, registered dietitians, pharmacists, nurse practitioners, but they have all gone through, board certification to become a diabetes educator. In terms of the format, it's delivered both one-on-one and in group settings. The group classes have been on hold with the PHE, and Medicare's and payers are covering one-on-one for the time being, as well as face-to-face and via telemedicine. And we've seen a tremendous increase in participation in DSMT as a result of telemedicine. So we hope that option will continue after the PHE ends. So as you might imagine, diabetes self-management training covers a broad range of topics that would be useful to a patient in managing this chronic disease. There is a lot of attention on nutrition and physical activity, diabetes as a disease state and complications, medications, not just what they are, but how they work, how you take them, what the side effects are, how to monitor, interpret, and manage glucose, coping skills, and preventing diabetes complications. And so one of the misconceptions about DSMT, and if you present this to a patient, they may say, "Oh, well, I've already gotten that. I saw a nutritionist a couple of years ago." Chances are they have not had DSMT. Chances are that they've been referred to a dietitian and had really focused nutrition counseling. DSMT is a lot broader than that. It is covering many more topics, as you can see here, and nutrition is covered in depth as part of DSMT. So we're really trying to reverse the practice pattern of having our patients referred to nutrition with diabetes and instead redirect them to DSMT, where they will get intensive nutrition counseling. If they have nutrition needs that exceed what's offered as part of DSMT, they can certainly be referred for medical nutrition therapy to a dietitian. Next slide. All right, so how to refer providers. So this is an ambulatory referral. You could type diabetes, it'll come up, diabetic education, DSMT, DSME, which is education and support. Any number of synonyms will pull this up. If you like the numbers, this is Ref 20 in the outpatient orders. Next slide. And we've done a lot of work this year to really streamline this referral and minimize the amount of information that the referring provider needs to enter. There's really only 3 clicks. You have to answer a question per Medicare about whether the patient is on insulin, and then whether they had any special needs that make them more suitable for one-on-one DSMT as opposed to group. For example, blindness or their wheelchair dependency or something that makes it hard for them to participate in a group class. So you just enter that and sign the referral. And next slide. And so what happens after the referral? So we now have a dedicated team of referral coordinators to help ensure that the loop is closed after the referral is placed. So patients will get an automated text message within 1 to 2 days, and they can schedule directly there. If we don't get a response by text, there'll be an automated phone call within 2 to 3 days. Again, if no response to that, they'll receive a live phone call from a referral coordinator, and hopefully the loop is closed. If not, next slide. We continue to do some outreach, so there's a second attempt and we leave a voicemail. It's a nondescript HIPAA compliant voicemail. And then if no response to that, the final outreach is a MyChart message with information about how to schedule. Hopefully we reach a large proportion of patients referred via one of these attempts, and then the patient schedules and they can select in person. Telemedicine group is sort of on hold right now, but may become an option soon. And then they complete the visit. And one thing that I'll point out that's different than the DPP is that DSMT, the frequency of visits is really individualized based on the goals that are set by the educator at the initial visit. So it's not like a weekly session as the DPP was. Typically, patients are being seen if there are a lot of urgent needs or a lot of needs. It's like maybe 2 to 4 weeks. Otherwise, it's every 3 to 6 months. All right, next slide. So again, here's our contact information. You can feel free to reach any of us if you have any questions about how this works or any feedback, especially early on. If you find that something's not going as expected, we definitely need to hear about it early on so we can fix it. But we hope that you'll take advantage of this important service for your patients. I know many patients in the Bartlett practice, are eligible for both DPP and DSMT. So with that, we'll stop and see if there are any questions.
Those are both amazing programs. This is like the most high yield 30 minutes I think we've had in a while. So there were a bunch of questions in the chat, I think, that were already answered, but anyone else have ones they either want to unmute and ask or?
Hi, it's Yuka. I just had a quick question for you about the camera thing. So access to telemedicine has always been a real challenge for people in our clinic. Even if we were to give them camera, they would have to have a computer or some other way to get online. So a lot of them use data still. I know that must be not the average here at Johns Hopkins. So I was wondering what your strategies were to get people who had poor access to the internet onto your Zooms.
Yeah, I can speak to that. So I will say, we all the 200 people that I showed you that have enrolled in our programs, they were all from our JHH zip code areas. So or they had Medicaid and lived outside of the city. So we've pretty much always focused on a population that may have fewer resources. So what we did, when we before the pandemic, we were in person. I showed you some pictures of that, and we didn't expect to ever have to use technology. I was very concerned. We had 50 people in our programs in March of 2020 that when we tried to go to telemedicine, we knew people could call in on the phone probably, but we thought that the interaction for, by video would be even better for the group. And we only had one person out of the 50 who could not use a smartphone to connect by video for the for the sessions, and that was kind of our baseline. That person called in, and we did see that as a as a potential problem, but the person wasn't going to have the access they needed. So it's not been as big a problem as I was concerned about. I will say that we have been because of the population we've been serving and are committed to serving, we have always made sure when we've written grants or whatever that we have funds to cover things like this. And whether it be by a new scale so you can weigh yourself if you use a wheelchair, or it's just basically like random one-off stuff that we've always done. You're right that if someone doesn't have a laptop or a computer, then getting a video camera is not very helpful, and we wouldn't obviously do that. But we always try to figure out with our CHW, our community health worker, what is it that we could do. We had a couple of people where they didn't have access, and we just got a spot for them during the pandemic in one of our conference rooms on the campus. Got that person in there. Didn't make them, didn't have them pay for parking. Made sure that they had transportation to get there, and then gave them a computer. So we will go through, because of our commitment to who we serve, we'll pretty much do anything to make it work. I would buy someone a laptop or a tablet. And I've been, worried about this for 6 years that it's not sustainable, but so far we've been able to make it work and always found a way to get that to work. But I totally agree with you. This is not that is exactly the kind of stuff that I worry about.
Interestingly, we had a meeting with Kevin Sowers the other day, and he asked the exact same question, but pointed out that even through this COVID pandemic, access to technology was a big driver of disparities, at large. And it's not something that this partnership can fix entirely, but I'll just also add to that, if by chance a patient can't do the telemedicine, chances are there is an educator near them, because we've got, at least for DSMT, a broad reach now within the system. And if there are transportation barriers, there are wraparound services built into this grant to pay for transportation to the clinic. So at least we can address that piece of it. I don't know that we can tackle the Wi-Fi access at large, though.
No, it was a fantastic presentation. Thanks. I guess we're trying to figure out what else we can do in our clinic, and we wanted to learn from your model. So I think we'll probably get in touch with you offline, because we have some philanthropy money, and I'd like to spend it wisely. So thanks.
Oh, okay. Great.
Oh yeah, happy to discuss. Ness, there's a question here about DSMT taking outside referrals. They just need a provider referral, right? This is the main thing for DSMT.
That's right. There is a link to the external referral on our DPEP website. So the link is there, and it's under the resources. We just need a faxed referral.
Trying to see if I can pull that up quickly for you guys. Is that right on?
And then if you guys send me your slides, I'll put them on our Teams channel and have it there labeled so anybody can refer to that for how to do referrals, and in our little Bartlett Clinic notes section. So
just one more comment about the referral, because I know that some of you probably have inpatient obligations. If you identify a patient in the hospital who's appropriate, the way to place this referral for DSMT is through the discharge navigator as a after discharge ambulatory order, but the order is identical. Just to be aware, you wouldn't be able to place it as an inpatient order.
Thank you for the questions. We're happy to come back and talk again, and please do get in touch with us.
Yeah, so I'll put on my calendar a little check-in point, and maybe we'll at least poll the group for this regular meeting and see how things are going, because like I said, there's so many patients who would benefit from this, and if we're not overwhelming you, we should try to start.
Awesome.
Yeah, please overwhelm us.
Overwhelm us. Yes. Thank you so much for having us.
Okay. Thanks so much.
Bye.
Bye.